Welcome to Day 2 of the Lean Gulf Summit. I am Dr. Deborah Solini, co-founder of the Lean Gulf Institute, which is a member of the Lean Global Network. I'm joined today by friends from the Global Network, and various other interesting things are planned ahead. I'm confident you will gain much value from our sessions today, so let's jump right in and get started. Please note we are adjusting the published Day 2 agenda to allow Dr. Fred 45 minutes to speak, and then immediately following, Flavio Battaglia will begin his session at 8:45 p.m. And now I would like to introduce our first speaker, Mark Graban. Mark and I first met years ago at the Lean Enterprise Institute and Lean Global Network headquarters next to MIT in the US. At the time, we both identified ourselves to each other simply as engineers who had discovered a passion for lean in healthcare. Mark had just finished his book, Lean Hospitals, the first edition, and Sam and I were there to meet with Jim Moback and others to explore the qualifications to launch the Lean Gulf Institute as a member of the Lean Global Network. Looking forward to today, Mark is now a well-traveled, internationally recognized consultant, published author, professional speaker, and blogger. Lean Hospitals is now in its third edition and has been translated into numerous languages, including Arabic. And Mark has kept writing new books, Measures for Success, Reflections from Lean Leaders, Healthcare Kaizen, and the Executive Guide to Healthcare Kaizen. He also advises KaiNexus, an improvement software company. So now let's hear directly from Mark.
Well, thank you, Deb. I really appreciate the opportunity to share some thoughts today. It's a real honor to be here. So thank you to the Lean Gulf Institute. Thank you to all of the sponsors and participants today, Dubai Quality Group, and thank you everybody for coming. So I want to share some thoughts around a vision for lean healthcare. As you see here on the slide, and I think it'll be shared in the chat, if you go to the link that you see there, you'll be able to access my slides and other additional resources, additional articles, videos, podcasts with some of the people that I'll have a chance to mention and talk about today. Because I can't speak for anyone other than myself, but I think there are a lot of shared perspectives about what lean healthcare means, and I'm going to share other voices and other perspectives beyond my own. So as Deb mentioned, I'm coming to you from the United States. I have had the good fortune to travel and visit hospitals in various countries in Europe, in China, in Thailand, in Japan, the US and Canada. And even if we just look at the US and Canada, there are differences in our high-level health system. But when you really start looking at how care is delivered, there are so many similarities. There are similar challenges, there are similar opportunities, and that includes opportunities for lean management. So hopefully, even though I will be sharing examples from the United States today, I'm not intending to share a vision for American healthcare, but I hope there's something for people from different countries who are joining us today. So as Deb mentioned, one of my books is indeed Lean Hospitals, and the subtitle states some of the goals or the vision: improving quality, patient safety, and employee engagement. You'll notice the subtitle of the book is not, reducing costs, boosting margin, and saving money, even though those are kind of all synonyms for the same thing. The focus really primarily is on safety, quality, and our staff. As Deb mentioned, the Lean Gulf Institute, thanks to them, translated the first edition into Arabic, and that book is available. That version in Arabic is available online. And so what I'm sharing today is based off of a chapter that was revised for the 3rd edition of Lean Hospitals, the English edition, a vision for a lean hospital and health system. And by health system, I mean really healthcare organization, a health system that contains, let's say, multiple hospitals and clinics and surgery centers. I'm not really talking about health system per se at a national level in any country. So to try to clarify some of the terminology there, I'm talking about lean healthcare organizations. And again, on this page at markgraban.com/virtual2020, I've provided, you can actually download a PDF of this entire chapter that today's talk is somewhat based on. So I invite you to go, please download that if you're interested, accept that as my gift to you. So I think, lean thinking and lean methodology doesn't start so much with what do we want to go do? What do we want to go implement? What methods are we going to adopt? It starts with our friend, and for a lot of us, our inspiration in a lot of ways, John Shook, who was the first American ever hired by Toyota as they were starting to expand globally into the United States. And as you see John captured here, he asks a very important question, what problem or problems are we trying to solve? And I think that's a very important starting point. And on that page that I've shared with you, there's a video of John speaking and talking about what he calls a lean transformation model, as you see captured in this photo here. The problems that we're trying to solve, again, in my experience from visiting hospitals and health systems around the world and reading and talking to people, the problems and the opportunities are very, very similar. If we want to frame lean in terms of, let's say, goals, and we can turn these into measures, arguably the goals that matter in any organization, really in any industry, can be described in 5 bullet points, a framework that I learned when I started my career in the auto industry at General Motors, not Toyota, but focusing on safety. In manufacturing, the focus would be primarily on employee safety. In healthcare, that of course also includes patient safety. Employee safety and patient safety going hand in hand. We focus on quality. We can talk about clinical outcomes that come from providing the right care the right way. We can also talk about service quality. In manufacturing, we would talk about delivery or on-time delivery. In healthcare, we might use a term access, timely access to care. And then, of course, cost is important. Even though American healthcare is the most expensive in the world as a percentage of GDP, I can't think of any country I've visited where people are happy with their current levels of healthcare spending. This seems to be a very universal problem of people saying and countries saying, we're spending too much, we would like to spend less. We would actually like to have better quality at a lower cost. And as we've learned with lean in different industries, that actually is possible when we go about process improvement and management and organizational improvement using lean principles and concepts. So as I'd mentioned, the subtitle of my book doesn't directly mention cost. Maybe it should have. But I think the generally accepted lean perspective is that lower cost is an end result of doing everything else well. And we've seen this demonstrated in many organizations. When safety and quality and access are improved, lower cost will follow. That's a different mindset than what many would call cost cutting, which in healthcare often means, the traditional approach to cost cutting would involve laying off people and reducing services, where with lean, we are trying to reduce costs and protect people's jobs through process improvement, being able to provide more care, the right care, not wasteful, but the right care the right time at the right place. That helps us deliver it at what's hopefully viewed as the right cost. And then the fifth dimension, so in the automotive industry, the mandate, or the mantra really, the mantra was SQDC, safety, quality, delivery, cost. And then it's also important to think about morale. How do we measure employee morale? I don't think it's right to put morale fifth in this list, because I think employee morale is one of those dimensions and measures where, again, if we have better safety and quality, better access, we engage people in a way that increases morale, all of that will lead to continuous improvement that leads to lower cost as an end result. So if we talk about lean, and if you will, the leanness of an organization, how lean is an organization, whether it's an automaker or a hospital, I would propose here that the level of our leanness, if you will, is measured by outcomes, not by the number of tools that are implemented. Or we could maybe add to this, leanness is not measured by the number of people you have trained and certified. Leanness is not measured by the number of projects that you've done. Training, tools, projects all contribute to outcomes, or they should, if we're going about this the right way. So that's one other idea that I would propose here. Instead of asking, what tool should I implement, we should be thinking about the problems and the goals and the benefits that we're looking for. So when we look at the impact of lean in different organizations in different countries, lean benefits all of the different stakeholders that we see in healthcare, including patients. Lean healthcare is about better care for patients. But then we look at other stakeholders that might be wearing scrubs or surgical attire or a suit and tie, perhaps. The providers of healthcare, the physicians, the nurses, the pharmacists, everybody else who provides care, everybody else who works in a hospital. I think it's a great sign when an organization, a healthcare organization, says every employee is a caregiver. And when they mean that, the people who clean the floors are also considered caregivers and need to be respected as such and involved and engaged, because the people who clean the floors are helping prevent infections. They are a part of the team, just like a surgeon. So we're looking for benefits to patients, providers, the payers, whether that is the government or insurance companies. We want to provide better value to the people who are paying for care. And we also have benefits to the facility owners, again, whether those are private or public organizations or military hospitals have the same opportunity to have a better bottom line financially or lower budgets while also providing safer, better care. So there's a general lean principle. Goes back to our friends Womack and Jones and the Lean Enterprise Institute and the books Lean Thinking and otherwise. The idea that value is defined by the customer. In healthcare, that's primarily the patient. So we could say value is not just safe treatment. I would consider that a bare minimum, that the treatment in the environment is safe. And value is often defined as outcomes. So not just the quality and the cost of what you've done. In some cases, it might be the care that you avoid having to provide because we're being more proactive and preventive. And I think lean principles help back up that idea. It's better to help maintain health, longevity of life, but also the quality of life. If we can orient our healthcare organizations and our healthcare delivery in a way that helps keep patients healthy and out of hospitals, I think that's better than improving the way hospital care is provided. I want to share some thoughts, and I apologize, this is intentionally provocative, and I'll apologize in advance when I'm sharing the words from Dr. Eric Dixon. So he is not only an emergency room physician, but he's the CEO of UMass Memorial Healthcare in Massachusetts here in the United States. kind of helping emphasize the idea that the best patient experience is a safe patient experience. So recently when I had a chance to interview Dr. Dixon in a podcast, he said the goals, what the patients want is, first, don't kill me if I come to your hospital. And what he means is, don't harm or kill me as the result of, let's say, a medication error or a preventable communication error. As the patient safety movement has learned around the world, a vast majority of errors, particularly those that cause harm or death, are preventable. So we want to orient our lean healthcare efforts around protecting patients. Don't kill me, don't hurt me. So stepping back to the origins of the term lean and the book, The Machine That Changed the World. Why were organizations like Toyota labeled by Womack and Jones and Dan Roos and John Krafcik, who worked with them? Why were they labeled as lean? It was a description of a production system and a management system. It was also a description of the outcomes, where Toyota and some other producers were significantly better than their competition in America and Europe. Half of everything, basically. As the book said, half the human effort, half the space, half the investment in tools, half the engineering hours, far less than half the inventory, many fewer defects, a greater variety of products. So we're trying to break trade-offs between quality and cost. We want better quality and lower cost. In healthcare, we might aim for the lean hospital or lean health system having half the errors, half the infections, half the harm, half the waiting time, half the length of stay in the hospital, maybe half of the employee turnover because employees are happier and they're choosing not to leave, half the cost, half the space, half the complaints. But we can maybe aim better than that. So reducing these problems in half is of great advantage to everybody involved. But as a machine that changed the world, illustrated for us a couple of decades ago, lean producers actually set their sights on perfection, working towards zero defects, working towards zero inventories, and endless product variety. So when we talk about this aim for perfection, going toward the ideal state. So again, we're aiming toward zero harm to patients or staff, zero delays, zero angry customers, zero voluntary staff turnover. Now, these are ambitious goals, but when we set an ambitious ideal goal, that can inspire people, especially when leaders are helping everybody work toward that goal. We're not just putting pressure on people. We're actually working together to improve the system in a way that helps us make progress toward that goal. So one other inspiring leader who came from manufacturing and then has had a great impact in healthcare in the United States, he passed away recently in April. So it was a great loss to those of us who had the opportunity to meet Mr. Paul O'Neill. He was the CEO of Alcoa. He was the United States Treasury Secretary under President George W. Bush. And then he was also involved in something called the Pittsburgh Regional Health Initiative and beyond. So when Mr. O'Neill was the CEO at Alcoa, their goal was zero lost work time injuries. He said, as the CEO, people should not be hurt who work for Alcoa. It, meaning safety, is not a priority, it's a precondition. And Toyota uses similar language, that safety is not a goal, it's a precondition. If we can't have safety, we shouldn't have anything else. So Mr. O'Neill talked about setting goals at the theoretical limit of performance, and that leaders work to eliminate excuses in the organization. So we might talk about our goal of zero harm, and people might list a long list of excuses or reasons why that seems not possible. The role of leaders is to work together and by eliminating excuses, I mean improving the system. We're not telling people to stop complaining or to stop talking about excuses. Leaders, especially senior leaders, need to work together with people to eliminate the systemic causes of safety incidents. And when Mr. O'Neill was CEO of Alcoa, you can see the blue line here shows a dramatic reduction in employee lost work time injuries. Did they get to zero? No, but they reduced harm and injuries by something like 90%. The purple line here shows the company's stock price increasing over that same time frame. So one thing Mr. O'Neill emphasized, and he talked about in healthcare, if we think there are trade-offs between safety and quality and cost, those are false trade-offs. It just means we don't know yet how to deliver both. And organizations in healthcare are showing this is possible. So one of Mr. O'Neill's students and proteges in healthcare was Dr. Richard Shannon. Oops, I think we need someone to mute themselves. We've got some background noise. But Dr. Shannon, when he was working in Pittsburgh and learned from Mr. O'Neill, he was inspired by this approach. He set inspirational, aspirational goals to have zero central line associated bloodstream infections. And as you can see in this chart, when they use the lean methodology for process improvement, ensuring that a standardized process for inserting and managing and removing central lines was being followed. And again, this is about improving systems, not just lecturing the staff to do better. They had a very immediate, very dramatic reduction in the number of infections. And at the same time, with the reduction in infections, that meant a shorter length of stay. It meant lower cost. So here's again where we have the opportunity to improve safety, because reducing these infections was literally saving lives. It's improving the quality of care, and it's also reducing the cost of care. We can and must do this at the same time. So in Lean, we talk about being patient-centered, trying to provide the right care in the right place at the right time. So I love an example from Minneapolis, and there's a video on the webpage that I'm sharing with everybody today. It's the Park Nicollet Cancer Center. It's called the Freundschuh Cancer Center. It's the name of the person it's named after. And one thing they noticed from observing the work and from being very patient-focused is that cancer patients were having to move from not just department to department, but they were moving from building to building. It's cold in Minneapolis in the winter. There's a lot of snow. And so they challenged themselves to redesign cancer care so that the patient didn't have to move from building to building. As you see from the video here, you have a patient in a reclining chair to receive chemotherapy. This is also now the same room where they are examined by physicians. So they had to literally invent a chair that didn't just recline, but it goes flat and then it raises up to become an exam table. They can do everything other than radiation treatment in the same room. So the patients are sick, they have limited energy. Their design principle, which became in a way a marketing slogan, is where care comes to you. And I think this is incredibly noteworthy from the standpoint of Lean being generally customer focused. In Lean healthcare, that means being very patient focused. Cleveland Clinic is an organization started in the United States that has what they call a patients first philosophy. And so in Lean organizations, the patient comes first. Leadership helps create the expectations and the systems that allow everyone to be patient focused. So this patients first orientation at Cleveland Clinic is something they've been able to build their Lean management system on top of. And as Cleveland Clinic has expanded and has a hospital in Abu Dhabi, they've brought that same patients first orientation and philosophy to their hospital there. So to talk a little bit more about patients before we talk about staff, What would the patient experience in a lean outpatient surgery center? They would experience better communication. There would be no miscommunications. Everything that needed to be communicated to the patient would be. Arriving and parking would be convenient and hassle-free. They would be able to register themselves without repeating the same information on multiple forms. It would, of course, be safe, high-quality care. We would be aiming for ideal care or perfect care. And at the same time, everybody, including the patient's family or parents, would get great service while they're waiting. There would be perfect communication, and there would be accurate billing if they're in a country where a bill is sent to them. So beyond patient focus, lean organizations are also really focused on their healthcare providers and employees in a deeply meaningful way. A lean hospital recognizes that employees are the true source of value for the patients rather than being viewed as a cost to be reduced. I'll share an example again from Dr. Dixon before I wrap up, that in a lean organization, top leadership makes a consistent commitment to all employees that lean improvements will not lead to layoffs. Lean organizations don't overburden their employees. Instead of pressuring people to work harder or to be more careful, lean hospitals and leaders at all levels engage employees in improving the systems that provide safe, high-quality, timely care. In a lean organization, employees are not sent home every time the patient's census drops. Instead, that time that's freed up is seen as an opportunity for Kaizen or continuous improvement. So in a lean organization, staff and employees and medical professionals of all types are challenged to grow personally and professionally, learning not just their technical skills, but their leadership skills and their problem-solving skills. And employees and staff would be happier working in a lean organization because they're able to feel a sense of pride. They're contributing to a high-performance organization. They understand how their role, again, whether they're a surgeon or a housekeeper, how their role impacts patients and their colleagues, the hospital's bottom line, and the community. So there are some slides I'm going to skip over, but you can read those if you go to the webpage and download the slides of some of these lean mindsets that leaders would share. But here's one that I will share before another story that'll help wrap things up before Q&A. So of all the different mindsets, and again, this is not just about the tools or the projects, there are certain mindsets that lean leaders at all levels would tend to have and share. These mindsets would influence their behaviors as leaders. So I think here's one that's very important. That a lean hospital recognizes that there is waste in every process. We focus on continuous improvement and root cause problem solving instead of workarounds and firefighting. So this recognition of the reality that there is waste in every process, that there are opportunities for improvement, is combined with the mindset that says the individuals are not blamed for the waste or the problems. Many problems, most problems are driven by our workflows, our processes, and our systems. So instead of blaming individuals, leaders have an obligation to help work with everybody and to engage employees in improving or redesigning or reinventing the systems that deliver care. And again, in the course of doing that, top leadership makes a consistent commitment to all employees that lean improvements will not lead to layoffs. This is a very important principle and leadership behavior that comes from Toyota. It's practiced by a growing number of lean health systems or organizations that would say they are practicing lean. But again, I want to share a story from Dr. Dixon, the CEO I mentioned earlier. During the current pandemic, healthcare organizations in the United States are facing financial hardships because there are elective surgical procedures and other clinics that are closed or working at reduced volume because of the emphasis on COVID-19. So during this financial situation, Dr. Dixon, as CEO, was talking about this tough decision that they made, how he had extensive conversations with his board, not just about cost and finances, but asking, what is the culture we're trying to build here? Dr. Dixon, over I think 6 or 7 years, has been working very hard to help build a culture of continuous improvement throughout UMass Memorial Healthcare. As Dr. Dixon told me, we didn't know how bad this was going to be, this pandemic and the financial impact. We didn't know how long the recovery was going to be. So we saw revenue drop by 40% in the month of March, and we could have saved $5 or $10 million through furloughs or layoffs. At that point, we said, will it be worth it if in 3 or 4 months down the line, we're trying to bring people back? We're trying to hire new people. So if you, as you learn about lean, I recommend a book called The Toyota Way. And the book, The Toyota Way, has 14 principles, the first of which says, make decisions based on the long-term perspective, even at the expense of the short term. So they looked and said, well, they thankfully had the cash situation. And they said, you know, we're going to stand by our people using what Toyota would call the respect for people principle. We're not going to furlough. We're not going to lay off. But we are going to ask every one of those employees to be an ambassador for the organization. We're going to ask every one of them, when they're not providing patient care, to look at the way they're doing their job and to spend time that would otherwise be downtime and to think about ways you can improve. This is long-term perspective. And by not saving that money in the short term, they've been able to actually redesign and improve many of their processes from a clinical standpoint and from a financial and billing perspective. Looking a couple of months back at this point, Dr. Dixon says, yes, we feel like that was the right decision, that was the best decision for the organization in the long term, or even the midterm, a few months out. So if you want to hear Dr. Dixon talk about this, there's an entire roughly 25-minute conversation I have with Dr. Dixon. You can find it, and I've linked to it on the page that I'm sharing with you. You can also go to valuecapturellc.com/HE11. I think it's very inspiring to hear Dr. Dixon, as what I would call a lean leader, talking about the commitment to the employees, the commitment to continuous improvement, and the commitment to providing the best care possible. I really admire and appreciate what Dr. Dixon has been doing. So final thought before we can do some Q&A. Again, as I mentioned earlier, I would propose leanness is measured by outcomes, not by the number of tools that are implemented, not by the number of people who are trained or certified, not the number of projects that we do. Because as Toyota reminds us in their illustration of the Toyota production system, as we're trying to learn and embrace and adopt and adapt lean to healthcare, I think we're well served by remembering that at the core, lean is about developing people. We develop them through their engagement in continuous improvement activities. That the Toyota production system is not just about the technical tools that we see here. It's also about managerial methods. And it's also about the philosophy and the mindsets. And as Toyota says, it's an organizational culture. It's an integrated system. So as we think about lean as an integrated system, my request or my recommendation would be, please don't copy isolated tools. Taking part of a system is not going to give us the same benefits as trying to build our own integrated system. And I would propose that that integrated system can be influenced by Toyota and Alcoa and companies outside of healthcare. The integrated system that you are hopefully creating can be influenced by organizations like UMass Memorial or Cleveland Clinic or organizations around the world that are embracing similar principles like this. So if you are new to your Lean journey, I say welcome. I hope Lean is helpful for you and everybody involved in your health system. If you've been on your Lean journey for a while, I would encourage you to keep at it. As I've heard one of my mentors say, kind of final thought I'll share here, the author David Mann, who's written a great book called Creating a Lean Culture, he says and emphasizes, it's not that Lean is really that complicated. It's just Lean is very different than the way many of our organizations are managed. So there's the challenge. Creating an integrated system, changing a culture, transforming an organization is not easy, but it's important, and that's why I think we do this work. So with that, I will put up on screen, here's the URL. If you go markgraban.com/virtual2020, you can download the slides, you can read chapter 13 from Lean Hospitals, you can listen to the podcast with Eric Dixon, you can, there's all kinds of other information that you may want to take a look at. Here's my email address, my blog, and my website. And with that, we have time for some questions. And I will do my best to provide good answers.
Okay, we have the first question from Shannon, and Shannon is asking, can you give us more information on how to improve safety behavior?
Yeah, so when you talk about safety, I mean, we can talk about behaviors, we can talk about systems and processes. You know, there are a number of Lean concepts that come to mind. So for one, leaders to improve safety have to help create an organization where it is safe for employees to speak up. And that employees and healthcare providers can speak up about errors that have occurred, and they can feel safe that they're not going to be blamed and punished. Because blame and punishment does nothing to prevent future errors. We want to make it safe for people to speak up about risks and to not be dismissive of those risks. A Lean organization doesn't say, oh, just be careful. A Lean organization uses concepts like error proofing to make it difficult or literally impossible for something to be done incorrectly, for something to be done in a way that harms patients. So we could look at technologies or processes. You know, it could be barcode scanning to help ensure that the wrong medication is never given to a patient. So, you know, again, you know, there are these combinations of mindsets and management practices and technical tools and culture that help us improve safety. If you know, we want to make it easy for people to do the right thing is part of the Lean philosophy there. That really helps lead to these dramatic improvements in safety and quality.
Okay, next question. What, in your opinion, can you give us some information with regard to for Lean implementation and Lean practitioners under the following circumstances? First is digital transformation, then the COVID-19 pandemic, and lastly, the near future challenges that we will all be facing.
So a couple of thoughts. I mean, we should ask one of the presenters from yesterday. I'm not an expert on digital transformation, but the one thing that I would propose that comes from Lean thinking is as we implement technologies, let's be careful that we're not automating a bad process. So digitizing might not be bad, but if we're digitizing the waste, we might not gain as much as if we combine digitization or automation or technology with looking at how the work is done, right? So let's improve the way the work is done, let's eliminate waste, and then let's digitize that. So that's one idea about digitization. And you know, I think in COVID-19 times, there's a renewed emphasis, I think, on protecting the medical professionals and caregivers. I think one of the greatest tragedies of this era is the lack of protective equipment, masks, gowns. I know that's been a problem in the US. I know that's been a problem in England. I would guess it's a problem in other countries. And sometimes the shortages of personal protective equipment in some instances have been blamed on lean. And so people might say, well, that organization was too lean. Or they'll blame, there's an element of lean. We talk about just-in-time production or just-in-time inventories. I think what happened in the pandemic is virtually unheard of, at least within the last 100 years. A lean system, an ideal lean system is not focused on low inventory. It's making sure, first off, that people have the inventory and supplies that they need. Now, it's incredibly difficult for every healthcare organization, I'll talk about the United States, for everybody to hold a supply of masks and gowns in anticipation of the next 100-year pandemic. If it's been about 100 years, it doesn't mean they're going to happen every 100 years. But I think there is a role and a place for the state, for the government, to hold a strategic supply of inventory. So in a lean framework, we might call this a safety stock of inventory, right? So that's one way healthcare is different than car manufacturing. One of the many ways healthcare is different than car manufacturing. Car manufacturing has very steady production rates, which makes it very easy to have just-in-time inventory. Healthcare, even in normal times before the pandemic, has much more uncertainty in variation in patient volumes. So I would argue in healthcare, lean inventory isn't about low or zero inventory. That lean inventory is about having the right supplies in the right place at the right time, and working together with a health system or at the state level or at the national level to have contingency plans for having a quick, agile response to unusual events. So it's easy to look in the rearview mirror and talk about the things that we should have done, but I hope as we recover from the pandemic that people will take a look, and governments will take a look at the right level of inventory that protects us in the future. So those are a few thoughts on, and then we've got to think about now a future where we have to provide billions of doses of vaccines potentially. How do we reduce the waiting time for those vaccines? That's going to be, I think, an important challenge to try to apply lean principles toward.
Okay, time for one last question.
Okay.
And that is, can you give us a few examples of resistance in healthcare when implementing lean from your experience, and how did you handle them?
Well, I mean, I think a lot of what gets described as resistance is often born from kind of elements like fear or anxiety. Like when people hear the word lean, that understandably might not sound like something positive. people might naturally, I understand when people are questioning lean because it has origins in car manufacturing and engineering. And people will say, they'll look at me, and this happens a lot. They'll say, you know, patients are not cars. I'm like, well, that's absolutely correct. That is a factually true statement. So we have to help people understand, like, if we give up too quickly, when we try to introduce lean concepts, I think we should expect that people should be skeptical and questioning. And instead of blaming them for that reaction, or instead of giving up on them, we need to continue the conversation. I think the conversation starts off much more constructively when we go back to John Shook's question and ask, what problems are we trying to solve? I think that's a better way to start the conversation, instead of asking, what lean methods are we going to implement? Because people can disagree with the idea of implementing lean. Hopefully they don't disagree with the idea of solving problems related to safety, quality, access, cost, and staff morale. So I think one way we get in trouble, and I've been guilty of this in the past and I've tried to learn from it, is don't lead the conversation with lean. Start the conversation with the problems, the opportunities, the goals, the benefits. And then instead of talking about lean, go and demonstrate in small ways how lean can be beneficial. You can get people on board. Dr. Fred is going to be presenting. I'd be curious, from hearing him speak before, he may touch on this, or I'll invite him to, you know, how did he first react to lean the first time he heard about it? And clearly he's become a practitioner of lean and an advocate for lean. So, you know, it takes leadership, it takes conversation, it takes time. It's, you know, but again, you know, I think that's a conversation worth having, even if it's not an easy one. And we shouldn't expect people, you know, it's not like turning on a light switch. We have to be patient. We have to be, you know, we have to continue having that conversation with people who are skeptical about lean, and recognize that that's a natural response that they might have when we first start talking about lean. So I hope that helps. We could have a much longer conversation about that, but we don't have the time.
Next keynote will be on learning and spreading lean around with Dr. Carlos Fred Pinto, Executive Director at the Hospital de Clínica Sul. And Dr. Fred, as he is also more well known to the speaking circuit and others, is a medical oncologist and executive director at a leading oncology group, Instituto de Oncológica do Vale, or IOV, in Campinas, Brazil. And he has led IOV's associated cancer centers. In his public and private practices in Brazil, cancer care has been provided for an area of more than 2 million inhabitants. In addition to his medical practice, Dr. Fred is Senior Advisor for the Lean Institute Brazil and a very well-respected member of the Lean Global Network, as a key contributor to the Lean Global Network's Lean Healthcare Initiative, which we will hear about more. He has also served as a board member for the Brazilian Cancer Society and director of the SBOC for more than 10 years. I would just like to point out that it isn't every day that you come across a hospital CEO and medical oncologist who personally led his organization's lean transformation, coaches people on A3s, follows his own standard work, and also gives back to the local and world community by sharing his lean learnings. He has done this in the US, Europe, Latin America, Australia, and today he is with us here in the Middle East. It's an honor to have Dr. Fred talk to us, and with that, I will turn the floor over to him. And thank you, Dr. Fred, for being with us today.
Hi, Deborah. Thank you for your kind words. Can you hear me well? It's okay here. Thank you, Doha, as well, for this invitation. It's a pleasure to be here with you. I will now share my screen and start my presentation. Well, I'll be talking about my experience as a CEO of a oncology group in Brazil, and how I've been working with several organizations to help spread lean through the healthcare system. Let me try to move it. So IOV is a small organization in Brazil. It's near to Campinas, but actually it's São José dos Campos. It's closer to São Paulo. And we are focused on cancer treatment. But our mission is actually to reduce cancer burden among us all. What I mean is that we all are touched by cancer somehow. Everyone knows somebody or has a parent or a spouse or a father or grandfather or grandmother that has cancer and can see the impact that cancer causes on us all. And as an organization, we want to be a global player, which means that we want to care for cancer in all possible circumstances, from prevention to the end of life, to the end of care for these patients. Oops. And how we are trying to do that so? We're trying to reduce cancer burden by improving the experience of care, the cost of care, population health, and how do we work? Simply using the PDCA as an A3. That's the basic value strategy for us at IOV. And well, if we're talking about outcomes, just like Mark said, and not about tools, we got a problem like 10 years ago. And we got this Dr. Laura Esserman from the University of California in San Francisco, thinking about a treatment center where a woman worried with a breast lump could get there early in the morning and have a diagnosis and a treatment plan by the end of the day. And we said, well, that's a great challenge for us. Because at that time, we got just like a board game for patients with cancer in the hospital. We use it to work in this hospital. I'm not working there anymore, but they are still there, but I'm not the medical oncology team there back anymore. It's a public hospital. Healthcare system in Brazil is very, very challenging. It's mixed. We can see it's like we have a public and private sectors and people going through both systems. But in that hospital at that time, more than 50% of breast cancer patients were more than 60 years old. They were living more than 1 hour drive from the hospital, and 80% were low-income patients. To get to their cancer treatment, more than 10 visits at the hospital were needed. And it would take like almost 4 months to get to chemo. And we were seeing more than 300 new breast cancer patients a year. So the point is that arriving by an ambulance from the public system, patients would go to doctor triage, doctor goes from triage sent to breast doctor that would order some blood tests, that would order some scans. And usually the system is not connected. You cannot do it. you could not do that at the same time. So you have to move. We have to go and come and go, and every point in this board game would mean she would have to go back home and come back another day until she got 60 days for comes and goes to get its cancer. After that would be one more visit to the anesthesiologist, and then a surgery would be scheduled. And more come and go and come and go, and then she'll find an oncologist. Well, we were working together there, and we said, well, the employee of the year should be the ambulance driver. He was the most closer person to the patient at that point. He was the guy that was seeing the patient every time. He was the really important guy in the hospital. We want to change that. So Shayla, who is still our nurse working with us, decided to change it in 2011. She got an A3 involving doctors, nurses, personnel, administrative personnel, with one question. I want you, doctor, to see my patient now. I want you to see the patient at the same time. So what she proposed on that A3? First, that patients should be seen in a logical sequence. All appointments should be done in the same day, from triage to breast doctor and an anesthesiologist. And once we know that we have an historical demand on these patients, we could leave open slots in the agenda for doctors. For doctors. And as well as we know the historical demand, we could leave labs, mammograms, X-ray, CAT scans, open slots. And chemo and radiation docs with also open slots. And then we created a Kanban to manage this flow. This was a real challenge. It took a little bit longer us to convince some doctors. That's the question that Mark asked. Well, the first reaction, the doctor said, oh, it's impossible. But we tried a little bit. And later, these doctors got really enthusiastic about that. So the real board game for our patient became a Kanban, a small Kanban, that would go all day long with the patients. Early in the morning, 7:30 in the morning, the patient would go to medical oncology triage, and we got separated flows. You got separated flows for these patients, standardized flows with tests, CAT scans, and X-rays as needed, blood tests, whatever. Lunchtime, and then she will meet the surgeon with the CAT scan, mammogram, X-ray, and other exams already available for the surgeon. By 2:30 p.m., she will meet the anesthesiologist. And if she will be elected for surgery, straightforward for a core biopsy, because she already got all blood tests needed for a core biopsy. So what happened to that patient? Well, in around 5 weeks, she will be on surgery or chemo if she's not eligible for chemo, for surgery. In 10 weeks, she'll get chemo if she needs surgery, because we need some time around here. We cannot go straight forward, but we got half of the time. So you remember Mark earlier? Half of the time needed to make it work. That's what we got. And of course, we got happier patients and we got safer procedures and better performance. Some of these patients, actually, we had to ask them to tell them that they were not dying. We were just trying to make it faster to help them. It was very, very unusual that for us at that point. So outcomes is what we are talking about at IOV. This is one pretty old example of what we're doing, but we've been doing lean at IOV at least for 10 years, and we got some real good outcomes for us. Like we doubled capacity in some of our facilities in more than 100%, 5% of our employees improve, 5% of work improvement per year per employee, meaning that 12 days of work are freed up every year per employee. Reduced inventory by 80%, energy consumption by 16%, overtime by 40%. Patients are waiting less 60% than they used to wait. We got, I will show you that later, patient on track more than 80%. We also got high quality standards, and we are one of the few organizations certified by the American Society of Medical Oncology. And of course, safety. Safety is one of our best achievements during these years. 85% more safer than we used it to be, and growing, fortunately. By making our people doing Kaizen every day, and more than 10,000 adopted ideas and alerts, doing like one day rapid improvement events 2 or 3 times a month. So actually that's what's happening now at IOV. We're doing real good performance. We have a great performance in safety. We're doing Kaizen all the time. We're doing rapid improvement events all the time and adopting new ideas all the time with a performance improving all the way along with that. But in 2013, we got a problem, and that's the story I'm gonna tell you. In 2030, we merged with a national group, and we got 2 times bigger in one day. So we were doing some Lean work since 2010, and we were learning about Lean, and we were doing quite fine at that point. Actually, we were very happy on our performance. But at that point, we had to double. And the fabric of Lean around, the knowledge we were building, the knowledge we got, we had to split all over new organizations that we merged, and we were facing a real challenge on that. We saw that we were losing the way of making. We were losing our best efforts to a huge new challenge. So we figured that we needed Lean leaders fast. And the strategy deployment that we got in 2014 to 2016 was obviously focused on safety. This is always the same at IOV. We are always looking for safety as one of our basic organizational goals year after year. But we decided to look about Lean leadership. And at that point, I asked Flavio for some help. I already knew Flavio. I was already using his knowledge to help us develop. And we created a plan together to develop a strategy deployment plan that it's named Hoshin Kanri at IOV to develop Lean leaders. And we created what we call the IOV Leaders Manual. What is all about? This is about our principles, how we were managing our system, that we were working on that already, but we had to share it and to make it like work for 2 times more personnel involved. What we said would be the desired leadership practices, the desired leadership behaviors, job instructions, and how catchball, that is escalating problems and escalating critical issues around every layers of our organization. How to do Gemba, coaching at Gemba was really, really important for us. And we kept doing these mini Kaizen events that we call like rapid improvement events, and standardized that. And this is a sample, like a plan for each of us. It's personal development plan and follow-up. and how a leader would help to understand TPS, understand leadership, expected leader behavior, oops, sorry about that, training, coaching, and so on. And how it used to be, well, actually how it's still going on. We created what we call the matrix for IOV. I'm a leader here. I'm sorry about that. I'm a leader here. And I got you got your pair, and you got an apprentice, two or three, and we will create sessions, learning sessions for layer 1 and learning sessions for layer 2, independently where you are. If you are top level management, you got learning sessions with the executive officer, that it's me, would be me. If you're in mid-level leadership, you will be leading your operational team. And we shared, like from 2017 to 18, we produced 38 A3s using this method. And this is one of the days that we call the Lean Day, where all of the 38 were presented to everyone and shared to everyone, with the coaching at Gemba and Gemba visits discussions for everyone. And what we got from that? Well, this is another example, very nice example that I really love this example of our navigation system. It's based on Kanban. And it's a problem that we face, and it's a really big challenge, because it's about the continuum of care. So just figure out here that we got three common types of cancer: prostate, breast cancer, and colorectal cancer. And these are blue, pink, and green. Pink, blue, and I don't see any green around here. And opioid, yellow. You see yellow here. So we were looking, all other were white. So patients facing challenges and being treated under these conditions were all managed by a Kanban navigation system. And looking for what? Looking for a continuum of care, looking for the complexity of treating cancer. And these patients, well, most of cancer patients are ambulatory care patients. They are not in the hospital. So we have to care for them coming and going from different places, different doctors, moving from different clinics, going to MRI, going to surgery, going to blood tests. And these patients faces financial restrictions, cultural and social challenges. They have communication problems. Most of our patients are older people that have some like hearing issues or understanding issues. They have problems with transports, access, and obviously the shame of being with cancer, or the shame of being so burdensome to his family. I mean, it's a burden that family carries. It's about the burden of cancer. So what we're trying to do is remove barriers for care, create a continuous and smooth flow for these patients using centered patient care, thinking about the continuum. I mean, the perfect care that we should look after. Doing what? Tracking, care transition, and timing of care, assuming that nobody has to feel in pain, to be in pain, no pain at all. So what we did was create a Kanban pack for each patient with standard of care for those patients. These are the standard of care for a general standard of care for breast cancer. This is the radiation oncology standard of care for breast cancer, chemo standard of care for breast cancer, surgery for breast cancer, and rehabilitation plan for breast cancer. And these are possible dates. What I was looking for is the next date is pulling my Kanban. And that's how we're managing those patients. And looking for those. So handovers, surgery, blood tests, or whatever. Critical events like visits to emergency department, hospitalizations that are not planned, toxicity, complications, and drug reconciliation. The plan of care, I will discuss a little bit more about pain, special care like rehab care, psychosocial, and educational care. This is an example of what happened with our patients when they are in pain. Every patient that start an opioid, we refer him to this navigation system, and a nurse starts a pain management protocol using these Kanban. These are the Kanban. And for those that you are used to that in the healthcare system, this is the World Health Organization letter for pain with the drugs we are using and how to use it. So, and this is the management for those patients, how to manage those patients. So it is an active management system looking for moderate to severe pain with 4 steps based on this standard work, these standards of work. Following regular checks. So check patient 24, 48 hours, 1, 2 weeks, and monthly. And see what happened. Emergency room admissions for pain reduced dramatically in just, oops, sorry about that again, in just few months. Actually, we're tracking since 2015, but the reduction actually was, the real deal was here in 2017. 80%, almost 80% reduction in pain admission for our patients. And this is really good. I mean, this is a real nice outcome for cancer patients, because around 80% of emergency departments admissions for cancer patients are related to pain. So that's a real good outcome, and we are very happy to provide this kind of care to our patients to be able to make them more comfortable and reduce cancer burden for those patients. And now we are doing that not just for pain, but for the 9 most common complaints for cancer patients. And we have an APP on cell phone that they can manage it, and our nurse here will open it in a desktop and manage those patients remotely, taking care of patients 24/7 and looking after what's going on and managing side effects of chemo or side effects of radiation oncology, or just complications of care that would not require a doctor intervention immediately. And this is another sample of what we're doing, like managing flow from our patients. This is the triage area, the chemo triage area. This is our daily production map. This is the screen for patients being served in one day at our clinic. This is the fast track. I will talk a little bit later about the fast track, that several patients, sometimes more than 20 patients are on fast track in one day. And this is how we, and this is how we work here. Workflows goes this way. So here is triage. The doctor will see the patient here and come back this way. So the patient will go to the nurse and plan care after actually, usually the patients go to the doctor and go straight forward to chemo. So this is why they got speed signaling here, and then zone of white, yellow, and red, meaning that red is a patient that is in the fast track. He will do the care in less than 30 minutes. So she has to work on the paperwork and replanning the next visit faster. Yellow, it will take less than an hour, and white, it will take more than 2 hours. So it's easy. You don't have to worry about these patients. And when you got in trouble, if you got any patient chart in this place, means the nurse needs help because they are overloaded. So that's the flow. Go this way and come this way. And this is any patients that need help with those the other Kanban, the navigation system will show up here. This is another sample from management board in the pharmacy, just to take a look at what is a daily workload at IOV, means how pharmacists will work on their activities. Activities to be done, already done, monthly activities, and daily KPIs. So we do morning huddles with daily KPIs, and we do this using, actually this is a real KPI using upper limit and lower limit of expected variation, following standard work for every procedure. Another sample about the same idea behind the Kanban and the navigation system is this Kanban for billing. It's basically the idea of making work visible, process visible, problems visible, and tips how to solve problems visible. We were growing. This is one of our facilities that more than doubled capacity during the years, but we have to make, oops, sorry about that. And we have to make more billing through a single day. So they save it with this board more than 150 days of work, because they're doing like more than 1,100 orders per month with 2.5 workers in this area, and use it to require like 3.5 workers. So they save it a lot of money, just creating standard procedures for billing and standard work for making the billing process, looking for what should happen today, what should happen tomorrow, and what should happen 2 weeks from now. Because so they look what I need today, what I need for tomorrow, and what will be needed 15 days, 2 weeks ahead. So with two weeks ahead, they have really enough time to order and manage and billing and do things like reviewing procedures. So you see the same C chart here, the Kaizen board where they discuss problems, the daily audit system, and here is the standard work, their standard work going in the small place that I have expanded here. And how do we do standard work at IOV? Well, we use TWI, training within the industry. That is a training system from the Second World War. Then we create standard work, and we manage them by daily audit systems. So training process, standard procedure, capacity, ability matrix, and how everyone is well prepared or fitted for each of these standard activities, and daily audits for each of these standard works. Actually, one a day. If we have like 60 different standard works, it will take me like 60 days to audit everything. But then I will do it again and again and again with a simple process of standardizing training, working, learning, and auditing. Whoops, once again. So we were doing quite well with our performance. I already showed you that. And so we're doing our best to improve care to our patients. And we were already supporting some organizations to learn about Lean. But the point is that our patients were facing poor quality care around the system. Besides, we were able to provide them good quality care, they were facing their challenging poor quality everywhere elsewhere. They were facing long waiting time to access appropriate care. So we figured that we needed to develop more people around the system. And then I asked Flavio help again, and using the same principles and the same value strategy, that is, we were also looking to reduce cancer burden, improving the experience of care, the cost of care, population health, and work processes, using PDCA as an A3. We created and started using the idea behind the manual to help other organizations. And we went to a big hospital in the city, a 400-bed public emergency and specialized care hospital. And we put together a team and started working in their emergency room in 2016. In 2017, we worked in patient flow and supply chain. 2017 also in image center, labs, and surgery. 2018 looking for sepsis, clinical outcomes, and supply chain 2.0 that we called. 2019 moving to improve the experience of care by noise reduction in the wards, ICU care, fall at ICU care, palliative care, labs again. And then in 2019, they went back to emergency room and created what we call the Kaizen shift. It's like training system for their own. Actually, now they're running by their own. They don't need any help for us. They are creating a very, very robust Lean system in the hospital. And we are very happy that we were able to help them and be part of this journey. But I will show you some of what they got as a result. These are the first emergency room experience door to door. And it was like 43% reduction in time door to door to high risk patients, and 25% reduction door to door in low risk patients, just with some few interventions they did there. So the supply chain A3 1.0, they created like a Kanban management. They eliminated like 18,000 kilometers walking per year, reduced supply expenditures by 10% a year, and reduced moving through clinics by almost 90%. But probably the most important achievement of all was that with the sepsis A3, the sepsis, so the generalized infection they opened, A3, they saved more than 180 lives from January to September 19. And they reduced hospital overall mortality by 4.5%. Just to remind you, this is a public hospital in a poor country. So we're working with very, very restrictive budget and very challenging environment for care. So they reduced it more than 25% of the mortality rate from sepsis with this A treat. They're very happy with that because we're saving lives. And this is something that really matters for us. But then we decided to go deeper in the system. So let's move ahead. Let's go deeper in the system. And why don't we do it with the whole healthcare system of the city? I live in a 710,000 citizen city. We have like 46 primary care units, 12 specialized care units, 8 emergency rooms, 400 bed hospital, the one that I showed you later, just the last one I showed you, and another hospital, 65 bed emergency hospital. So we went to work with them in the late 2018 and it started working together. Before that, we went to the public cancer hospital and created new flows for them and say, well, why do I work with all of the time with cancer? Well, maybe because I'm a medical oncologist and it's easier for me to convince medical oncologists and doctors like me that I could help them. So we redesigned the flow to improve access at this public hospital that is not owned by the city, but works for the city to focus specifically on cancer care. So what we did, we created new flows, 6 months training, and just more 10% personnel, which means 1 pharmacist and 1 nurse in a transition process. In 2017, they were caring for around 430 patients a month. Now they can see almost 1,000 patients a month, 930 patients a month. And we did just 2 basic stuff. We do queue management, creating fast track, regular track, and special track for their patients. And this is quite simple to make. I mean, this is not hard stuff to do. And separated patients in 4 families. Chemo fast and regular. So chemo fast and regular is here. Oral and follow-up, special tracks. Doing that, we doubled their capacity very fast, very quickly. Was not that hard to make. We did this before at IOV. We did this before in other oncology centers. So with that room in the public cancer center, we decided to work thinking about improve access to emergency and to other areas. So using the same strategy, creating a dedicated flow for its patients. So creating a dedicated flow for these patients, like a fast track for patients considered blue. Blue is low risk patients in an emergency department. Creating standard work for doctors and standard work for nurses. We were able to reduce 31% time door-to-door in emergency room. Like door-to-door in emergency room before was 4 hours mean. Okay, this is the C chart of it. It's very hard to see because we're talking about the measurements we got back there was 34,000 patients here and 15,000 patients here, because it's an emergency patient room that sees 12,000 patients per month. So it's a very crowded emergency room. And we were able to reduce by 31% door-to-door time from 4 hours to 2 hours and 45. And nothing is better than looking at it. So that's before the hallway crowded, and that's after. So surely we improved care for hundreds and hundreds of people a month. And what's better, doctors are more comfortable with that and safer with that. And patients are safer as well. We also improved in the system, blood sampling collection in primary care units. They were able to double capacity to offer blood sampling daily. So they just not doubled capacity, but they were also to improve response to exams from 7 days to 1 day for independently. If you got your blood sample collected today, you'll have results done to tomorrow. So we're very, very happy with that. And just doing some A3 and doing a value stream of what was happening there, they were able to figure out what's going on and improve the system. The same happened with the supplies. So look at those supplies before and how they were managed before. Oh, that's terrible. I mean, it's not possible to manage this kind of inventory. And so you have more inventory than you need, and you cannot know, you have no idea what's back in that boxes or whatever. You have no idea what's going on and if you have or not supplies. But now they manage everything. They did a huge 5S and huge inventory management system to make it work better. And guess what? Savings over 65%. Savings more than 4 million reals a year. It's almost 90% economy in logistics and 65% economy in supplies. That's a large amount of money for a poor country and for a poor system. Chasing money everywhere, it was just waste. And we were also able to improve and eliminate waiting for doctors. We call that the turtle game for doctors. It takes so long to get a doctor. It was to be more than a year. Using the same idea, dedicated team, Gemba-based work, data-based work, using leader's manual, A3 problem solving, thinking about queue management, fast track, regular track, special track, and daily management, Heijunka boards, leveling boards, and daily and weekly hulls. So looking for specialists, they increased capacity by 1% and improved access by 50%. Okay, 1% of increasing capacity is less than 10% of what they saved with inventories. They were able to increase 50% access in specialists and reduce almost 60% of delays to access specialists. Like this. First year update with the program. This is the Heijunka board for prostate cancer. So these are used to be all prostate cancer in the city waiting to access doctor. So now what it used to be like almost a year to access doctor. Now patients with elevated PSA, that it's a blood test for prostate cancer, will see the doctor in less than 60 days. But if the PSA is over 10, he will see the doctor in less than 2 weeks, based on this program. To access orthopedics, less than 2 weeks, cardiology, less than 3 weeks, ophthalmology, 3 weeks, and cancer surgery, less than 4 weeks now. All of these they've done using simple tools, queue management, Heijunka boards like this, and managing projects on daily basis, looking for through huddles and systems and several layers of evaluating care. So I'm finishing my presentation now. I just want to introduce you that we are doing this as part of the Lean Global Network and the Lean Healthcare Initiative. I've been working with Flavio here for a few years, and we have people working elsewhere. Flavio will go deeper on that later. The but what we're actually doing is thinking about the principles that Flavio will go deeper, is thinking about how important it is to you start your initiative and don't think that you need to have approval of your leader. Be clear what the next move you have to make. What is your next move, and what is what the problem that you care about? And thinking about the right knowledge. That I think that was one of the big hit that we did in our program, is thinking about the right knowledge for the right people at the right time. We don't think about inventory of knowledge for our teams. We create the knowledge as we understand the problem. Knowledge and problems goes together, and we keep doing on that. And obviously we learn from each other. We cross-pollinate. We learn from our partners and from our friends, and from looking how good looks like in the system. So that's it. That's the idea. These are the team, the team that are working with us in the city. The head of the hospital, head of the cabinet, oncology doctor, emergency, head of emergency, and we got a lot of chief architect. We got a lot of people working together, trying to make a better world for us and trying to reduce not just cancer burden, I think now, but to improve care for everyone. So thank you. And I think I got into my end here. And I think I'm not bad about time. Am I, Debbie?
You're right on target.
Great.
Okay. For our audience, I just want to let you know that we will now proceed with Flavio Battaglia, and his keynote will build upon Dr. Fred's. And we also had a situation where we had Todd, who was scheduled to do a training session later today, and for personal reasons was unable to join us. So after Flavio finishes, what we will do is we will have Dr. Fred, Flavio, Mark, and myself conducting a just-in-time training session, which we have been coordinating over the last 24 hours. So we're doing our own lessons in being adaptable and addressing the needs of the customer, all of you who are watching, because we did have some feedback from day one that people wanted more case studies. They wanted to see more practical application. So with that said, let me introduce Flavio. Flavio is a director at the Lean Institute Brazil and an MBA professor in Sao Paulo, Brazil. Flavio joined Lean Institute Brazil in 1999 as a trainee, shortly after LIB's foundation. He also had the opportunity to spend months inside Toyota to better understand the Toyota production system and further develop his lean skills. Flavio has worked in many industries and together with Dr. Fred and others has been bringing lean healthcare to South America and beyond. So with that said, the floor is all yours, Flavio. And thank you for joining us today.
Thank you very much, Deborah. Can you hear me? Is that okay for you?
Yes.
Okay. So good evening, everyone. It's an honor and a pleasure to join you at the 2020 Virtual Lean Summit. I would like to thank my friends Sam and Deborah Salimi from the Lean Gulf Institute and also the Dubai Quality Group for this amazing opportunity to share some of the things that we've been learning during the last years. You know, more than ever, the development of agile, adaptive, and efficient healthcare systems is a clear priority around the world. We've been noticing this specifically now, the times that we are living. And over the past decade, lean thinking has helped transform countless healthcare organizations around the world, improving patient care, working conditions, and overall performance. Yet, achieving a full lean transformation still takes too long and healthcare leaders and lean practitioners continue to focus on how to increase the impact of and the breadth of the lean transformation. And among the most critical factors are the time and the effort required to consolidate the internal capabilities of the organization, that the organization needs to really sustain the lean transformation as the time goes. Otherwise, there will be no sustainability. Okay, so first of all, let me give you a little bit of a context. Well, I work for the Lean Institute Brazil, a nonprofit organization that is located here in Brazil, in São Paulo City. And we are part of the Lean Global Network, the LGN, that is formed by 30 institutes around the globe. Personally, I joined the Lean Institute Brazil 21 years ago. And since then, I had a chance to work with many different companies from different sectors, different sizes, and different purposes. And approximately 12 years ago, I started my learning journey in healthcare by directly supporting clinics and hospitals interested in doing lean with our support. Then in 2015, I was invited by LGN's executive committee, specifically from John Shook, the gentleman then Mark presented to us. John is the chairman of our global network, and John invited me to coordinate a global study aiming to increase our understanding and our knowledge on how to transform healthcare with lean thinking and practice. So what I'm going to share with you now is the essence of what we've learned together so far. I hope it can inspire you and your organization on how to design a more agile, a more effective, and a more sustainable lean transformation. So the first thing we did was establishing a meaningful purpose. So would like to really have a clear notion what was the purpose. And of course, as lean thinkers, we established a bold problem statement to get started, or the major issue we would like to tackle. So what you see in this slide here is, in fact, is a handmade draft of our first plan, the first version of our plan, and we've been pursuing this plan since then. But what I would like to highlight here is our major purpose. So we would like to fix healthcare around the world. It's a very ambitious objective. It's a very ambitious purpose, but we think that this can give us a clear notion where we should go for. And the problem statement is, how are we going to reduce the time, the lead time, and the effort so your organizations can create the capability faster and in a more strong way. And then we decided to work together, learn together, so we could understand the current conditions in different countries, so we could have a notion how can we compare these organizations and try to find somehow the key success factors to help us accomplishing this objective. And we soon realized that the best way of doing that was going to see each other's work at the Gemba. Gemba is the Japanese word for real place, where the value-added work takes place, or the shop floor. So we decided to go to Gemba together so we could grasp the situation, we could better understand what was happening in different countries. So we started with United States, Spain, and Brazil. And so we went to hospitals together to observe, collect data, and have a common understanding of the multiple dimensions of the lean transformation. The next slide here is just a quick view of our learning journey, the things we did together, the things we learned together. You can also see here the moment where new people were coming in, so the group become a little bigger as the time was running. And again, this timeline, it finishes in 2019, but we keep working, we kept working since then. So the Lean and COVID-19 article that I will mention later is one example of the things that we keep doing together. So I just would like to let you know that these ideas that I will share in a moment are in fact a result of a long learning journey that I've had a chance to coordinate with the help of many others, including Dr. Fred. So here's the cover of the white paper. So we tried to combine the ideas, the learnings, into some specific written content so we could share it with you. So here's the cover of the white paper. I recommend everyone to have a close look at it. I think it's complementary to what I'm going to share. It's a free content. It's available on Planet Lean website, the electronic magazine of LGN. Of course, we wrote it. This is important. We wrote this paper having in mind the lean practitioners, the people who would really like to try those ideas and put them into place. So the things that I'm going to share is having in mind the people who really need to understand how to do things. So that's our source of inspiration to share this knowledge. And here's the, as I mentioned before, we keep working. This is the print screen of our more recent publication on Planet Lean. It's called Fighting COVID-19 with Lean Healthcare. It's totally based on real examples of how mature lean organizations start dealing with COVID, redefining core practice inspired by the lean muscles they have developed along the years. So just before I go to explain a little more in that, the principles, I would like to share with you how did we organize ourselves to do this, this study, the methodology that we followed. Well, first of all, we went together to grasp the history and the current condition of relevant lean initiatives in different countries. So we went together to US, Spain, and Brazil. And the second phase, we started to gather some facts and data from those 3 organizations that we visited together, but we added 5 more. So we gathered facts and data from 8 healthcare organizations from 5 different countries, all practicing lean for at least 3 years. So the sample that we chose to study, it requires the organization to be in this lean journey for at least 3 years. And we used the 5 dimensions of the lean transformation framework that I will introduce you in a moment. Then, of course, we structure our findings and then draw parallels within these multiple cases by comparing and specifying major success and major failure forces. So what we did were really try to identify the possible mistakes and the dimensions that will be impacted if people are not aware of some of these key things. And we identified the critical transformation characteristics directly associated with the lean capabilities development across different levels of the organizations, and which summarized our knowledge into these 5 guiding principles that we put together in the white paper. So here's just for you to have an idea of how these things were happening. That here is us working together in Barcelona, in US, and Brazil, then again in Barcelona again, and we did another meeting in Spain after 2 years to really wrap up the knowledge that we were putting in place. So part of the method was inspired by the lean transformation framework. What it is, it's a very simple way to understand the key dimensions an organization must be aware if it really wants to go into a deeper and a more sustainable lean transformation. So it all starts with the problem we're trying to solve. So Mark mentioned, he also showed us John Shook with the house at his back. It's the same house here that I'm showing you, the LTF. So we start with the purpose, is the roof of the house. Then we dedicated efforts to improve the way the work is organized. Then we start thinking about how to develop capabilities here in the middle of the house, or the management system and the leadership behavior. And all this, of course, is built upon a series of values and a very specific way of thinking in terms of waste and problem solving. So this is basically the framework that we used to gather the data, and we compared. We put those information together and tried to find here using this. Of course, here is just a draft of the method that we use here to compare the interventions, the way the organizations were doing this. So when we came up with the 5 principles. So the 5 principles are in fact a result of our learning, and here they are. Fred has shown you some of them, but I will try to explain it in a more deeper way. So the first one is don't wait for the CEO. The second one, what is your next move and why? The third one, make it your own problem. the right knowledge for the right people at the right time, and what we call the cross-pollination. So the first principle, don't wait for the CEO for one very specific reason. CEOs are very busy, and at some point in time, they will leave. They leave. I mean, if the transformation is only sustained by the figure of the CEO, sometime in the future, we will have faced some trouble. In fact, don't wait for anyone. We realized, studying the experiences of successful and failures of different organizations, the most sustainable ones are those who are not strictly connected to one person. It's embedded in the way people do the work. So, of course, having the CEO by your side is always great. Not every company is an Alcoa who has Paul O'Neill trying to change things. Alcoa was very fortunate for having him, but not every one of us has a guy like him behind us. So it's possible to start doing lean at any level of the organization. So this is what we learned. Of course, if you have the senior management engaged, celebrate it. But if you don't have it, don't wait. Do it the right way, and the CEO will notice. The senior managers will notice, for sure. Clearly, of course, what is needed is to clearly understand where the CEO stands and try to grow a relation by reporting progress frequently. And of course, what we also learned that you can do it alone. You have to find influencers, people that can help you doing that. And one important thing is try to find a chief architect. Dr. Fred mentioned chief architects. We created this name. Would like to make clear the role of one specific person, that is a person who is in charge of thinking the system, of thinking the management system, of thinking the intervention path. So this person is a key figure inside the lean transformation, because where the knowledge is anchored, and it's from where it will spread. So trying to find and build capacity for the chief architects. The second principle is what is your next move and why? Because what really matters is what you are going to do next. Some lean initiatives, we realized it studying the sample, the cases that we had a chance to study. Some lean initiatives live from the past. Every time they will share something with you, they will share something that they did 6 months ago, a year ago, and where we saw the burning flame of lean, it was directly associated with the organizations who had the next step clearly designed. So thinking about what comes next. This is what really important. Of course, why you are doing this next step. Patience must come first. I think Mark and Fred told it many times. So when we are deciding what we will do next, please think about patient. Patient must come first. And the first moves are decisive, like playing chess. You have free moves in the very beginning of a play, but as time goes, your degrees of freedom start to decrease. So think about what should be your first or your next move very, very carefully. Align improvement to what is important for you right now, and try to make the business needs, the people needs, and really try to vinculate those things. Stability must come first. We really should try to search for predictability, for stability, before trying to improve things that are not stable. So carefully, we recommend you to think about how to put things in a stable condition so we can start thinking about true improvements. The other thing is make the work and the process visible, so people will soon realize what they should do next in terms of improving or managing in a different way. Other important thing is lead by asking questions, not giving people answers. Leaders are giving people answers all the time, are telling people what to do all the time, and we realize that the organizations that are more successful, the leadership has a different way of behaving. They try to develop people by asking questions. It's a very unique way of doing that, and it's a very effective way of doing that. And all the time, every time, to balance our efforts between the social and the technical side of Lean. Lean, of course, is a set of tools, of techniques. People love the tools. They love learn how to use the techniques, but there is a very important side of Lean that is associated with the social side of that. It means, how do people deal with other people? How do people deal with the work? How people deal with the customers? I mean, this needs to be balanced. Otherwise, we will just learn tools and we will realize that the tool won't work for us if we just copy that. And I think Mark, they made an important remark about that. And just to emphasize, don't fall in love for the tools. It's a trap. The third principle, we call it make it your own problem. What we mean by that is that the ownership of the area managers, the local managers, is the key. And we realize that the organizations where Lean is really embedded in the culture, you see it in the area managers. You don't necessarily need to have an improvement team working for him or for her there. So when the area managers own the problem, things are very different. So, and a way of thinking about problems in the Lean perspective is that problems are treasures. Mark did mention it, and we must create true space for scientific problem solving. So we need to let people put problems in the discussion, where they don't need to be afraid of showing things are not going well. So Lean is the opposite. It's opposite of that. What we are really trying to do is make people aware that the problem, it can exist, it will exist. And we must give people the power, the authority to tell them they have a problem, because this is the only way we will surface the bad things and we can tackle that. So this is important. We need to adjust our mindset and our practice to different contexts. If we need people to own the problem, we need to make them not feeling guilty for that. So it's very tricky on how to start that, but we need to make people aware that the problem are really, it's part of their work. They need to solve problems as they do the work. It's part of the work. And of course, sometimes we discover that the responsible people are not aware of their responsibility. So we must work on that. And sometimes, and most part of the time, we discover that people are not emotionally connected with problems. So if people don't care about problems, if they're not emotionally connected with that, probably this is the problem that we need to solve first. Really make people aware of their role in problem solving engine. And as time goes, we need to win people from dependence on the improvement team to create ownership and strengthen their capability. And of course, reflect, seek support and new perspectives when progress stalls, because it will. Sometime the progress will stall and we need to do something in a different way. The fourth principle, we call it the right knowledge for the right people at the right time, for one specific reason. If we don't look at it, we for sure we will overload people. Healthcare professionals are very busy, so it's important to avoid hours and hours of training. Exactly because we don't want to create learning inventory. We don't need to batch knowledge. So we need to be able to teach people when relevant, when the real things are needed. One thing that we learned by observing the cases, by talking with the people, by working with them, is that the complicated tools can move people away. So try to avoid complicated things. Most part of the problems in healthcare systems can be tackled by using, simple and very straightforward tools. So every time we saw complicated tools, we found in the same way, in the other side of the coin, very frustrated people. So try to avoid it. Right knowledge, right people, right time. Important to give people time to build confidence and competence and connect mindset to the practices and tools. If you don't use the tools, if you don't just use the practice and you don't know what is behind that, what is the way of thinking that is driven the behavior, for sure the deep learning won't happen. And the last but not least important thing is what we call the cross-pollination. Cross-pollination is a way we found to call the learn through sharing. We realized that the most successful organizations were the ones who were able to share what they know and to learn from others and with others. So get people inspired by internal and external good examples. So, because the deep knowledge comes from practical experience. And we strongly believe that if a manager or a director or a supervisor, if he or she goes and see how his or her peer are doing things, it for sure will inspire him or her much more easily than inside a classroom with a lot of hours of training. So go in and see what good looks like. Understand and see what good looks like to guide your journey and your improvement. IOV did it a lot. Dr. Fred mentioned some of the interactions that they had, but they had a lot more. I will invite Dr. Fred to join me in a couple of minutes because what I'm going to show next is something that is related with him. So Fred, if you can jump in, please, it's a good moment. So the other thing is that the fresh eye are a great source of feedback on your progress. So when you bring people to see and you go see different things, it's something that will happen. You will learn and people will learn from you. And it can take place within an area, between different areas, among different hospitals, among different organizations from different sectors, lean practitioners, managers, teams, events, and a lot of possibilities, including events like this, a virtual summit, or we strongly believe that these things can inspire you. And yeah, so these are the guide principles, the 5 things that we found, and we tested our assumptions. Dr. Fred, unfortunately, I was not with him and with our team. I had my baby was born like the month that they met. But Fred, Oriol, Denise, and Alice, our core team, they went together for an experiment in the Stanford Children's Hospital. So to test those assumptions. And they did an amazing job with the outpatient MRI. So Fred, I'm not sure if you're listening to me.
Yes, I am listening.
Okay, so I would like Fred, if you could just help us sharing some of the things that you did together in Stanford. I think it's an important moment to share with our audience how those ideas, how do they fit, or if they don't fit for at the Stanford Children's Hospital, please.
So it was an experiment to go over these ideas and figure out if going into a different environment, these ideas would work. So we went for 3 days, 1 pre-work day, 2 working days in the Stanford MRI, Pediatric MRI Center. And they did some pre-work in there with value stream mapping. And so Denise was already working there. So they got a team. But we went as coaches to help them improve their system. And they were facing big challenges about delays, waiting time, and long time to get access to exams. So we discovered a lot of stuff there, and by the end we were able to improve some processes, and they did big changes in their system, and actually improved their capacity, I think, by two exams a day. That it's not so few for an MRI, and it represents a lot of more patients going on a year into treatment. It's a training hospital, it's an educational hospital, so most of their procedures are related to scientific studies, protocols, medical protocols going on, and testing treatments. So it's very hard. They had like more than 40 or 50 different protocols to follow up. And they did a great job together with us to shrink that large amount of work. Actually, at the point they started the system, they were not even looking for that. And that's the great idea behind bringing fresh eyes to a system, because they were not even thinking that it was possible to look at that and say, oh, let us revise and we revised that, and they shrinked the process. Like, usually took 3 to 4 days to schedule an exam, and now they are just scheduling exams on the first call. So usually it took, I want to schedule an exam, and okay, I'll call you back in 48 to 72 hours to schedule our exam. Now they're able to schedule an exam, say, oh, your exam is scheduled for next week or the other week or whatever, and then they will do the work together to figure out. So it was really a nice experience, and we were able to test what we're talking about.
And also, Fred, we had a chance to experiment those principles in other organizations that we are working together now. So this was not the only chance we had to put those principles into action. And I mean, this is kind of shaping the way we work with companies now. And I think, yeah, this is the thing that we would like to share with you. Thank you very much, Fred. Thank you, Deborah. And I think my time is gone. And thank you very much, my friends, for your audience. Thank you very much.
Thank you very much, Flavio. That was very interesting and informative. Now I am going to invite all of the healthcare panelists to join me online, as we are going to move on with the next portion of our day here. And we are going to start to have a panelist discussion that is going to be based on questions that you may ask and things that we feel that is important to emphasize. So in other words, kind of summarize and give you some takeaways, as well as address any issues that you may want to discuss. So with that, I ask that panelists join me.
I'm back. Hello again.
I'm here.
Okay.
I'm here too, yeah.
All right, great. And for our audience, I highly encourage you to post your questions in the Q&A. And let's get started. One of the things that was mentioned earlier was that managerial methods and lean are an integrated system. Would anyone on the panel care to elaborate on that?
I think we can go, all of us would do. Maybe Mark can start, and I'll go and Flavio go, so, okay.
Yeah, I mean, I shared that idea, and again, I think there's risk of adopting parts of an integrated system and expecting that we would get the same results as an organization that has an integrated system, right? So the one example that's often used, let's say, look at cars. A Mercedes is an integrated system. There may be parts of that Mercedes that are not as good as the parts on a Lexus or a BMW or a Tesla. But you can't just go pick and choose, well, I'm going to take some of the parts from the Tesla and some of the parts from the Mercedes and expect to be able to drive down the street in it, right? So there's risk, bringing it back to lean. Let's say if somebody says, oh, I like the idea of the strategy deployment wall, and I'm going to put up charts and graphs, but then the organization is not embracing the philosophy and the managerial behavior of looking for systemic root causes. So they put up the strategy deployment board and the chart. So they put up a huddle board in a unit, and then they do nothing but yell and scream and blame people for poor performance and pressure them to do better. Like, well, you'd be better off not putting up the charts in the boards. I suffered through some of that 25 years ago at General Motors. General Motors would try to copy elements of the Toyota integrated system. And a lot of it was either just a waste of time or counterproductive or frustrating to the people involved. So it's difficult to change in organizations' habits and a leader's habits, but I think we need to at least be aware. Like, if we don't have that fully integrated system, I'm not saying you shouldn't try, but I'm just saying you should be aware that there are going to be moments of conflict that come up when your existing culture comes up against with new practices from, adopted from, if you will, a lean culture.
Well, I can say I faced the same challenge before. Actually, when I said in the presentation that it was about our lean fabric, I was talking about exactly this problem, because we were developing our own system and our own culture, and we have to jump two times more people into the system. So people start arguing, why do we need this board? Why does it exist for? And when working with the guys at the public system here in the city, we're facing the same challenge, because more people are coming in, and there's a lot of knowledge behind, there's a lot of behaviors behind what's going on in the walls. And this is not just looking at the wall, and this is not looking at pieces of it. So the challenge we're facing now in the city is how to make those people that are getting into it right now get the right behavior and the right knowledge that Flavio was talking about a little bit earlier. The right knowledge, the right behavior needed to make a system work as expected, because the system is designed to deliver what is expected as a system. So it doesn't matter whatever you say, it will work like that. And we have to learn about it and to understand what's going on and what's behind the walls, what's going on, the people's side of change.
Fred, just adding something on that. When I showed you the LTF, or the Lean Transformation Framework, in fact, the LTF is a way to understand the different layers of this integrated system. What we call LTF, in fact, are dimensions that we must be aware to integrate those things. So we have to integrate the way we improve the work, the purpose of the people, the way we develop people, the way the management work is organized, and how do the leaders behave. So I mean, and the way they recognize the reality. So those elements, in fact, it's a way of understanding what are the layers, what are the elements that we must integrate to try to do a lean transformation. And of course, it can be fractal. This is a very important concept on the way we think. Lean can be a very small thing with all these dimensions combined, or lean can be in the whole organizations with all these combinations combined. I mean, we don't need to exactly think bigger in the first moment. We can start small by having all these integrated pieces. So in fact, this is the most recommended way of getting started. Start by thinking about all the elements, but starting small. Try to experience before. Then you need to start getting bigger and bigger and bigger, and spread it to different areas and different processes. So this is kind of the way we used to think about it.
Just to add to that, lean in healthcare, and for that matter, across different industries, is not a one-size-fits-all. As part of the experiment, you have to be willing to look into things and be open, be flexible. And these are soft skills. They're not tools, not directly lean tools. And I think that that's something that is really a very important message, because being excellent just technically in the tools is not going to guarantee you a good lean transformation. Any other thoughts on this subject?
Deborah, you're on mute, I think.
Yes, I was waiting to see if anyone else wanted to jump in. But I will go back and I will look at some of the questions that we are starting to get. One question is, what are the possible risks in not having a lean healthcare?
To reiterate a little bit, the risk is unnecessary harm and death. Sorry that that's morbid, but that's the reality. The risk of not having lean healthcare is that patients wait too long for their care and their treatment. There's risk that highly trained, highly motivated medical professionals get burned out and quit their profession. There's risk that a country is bankrupted by healthcare costs, or there's a risk that care is rationed. It's easier to identify some of these problems, and lean is not necessarily lean is not a magical cure-all, but the status quo in most countries is unacceptable. So whether it's lean or something else, we've got to find a way to drive something that's more than just incremental improvement. We can't afford to get 2% better every year. Lean, is really demonstrated to provide, an opportunity for big leaps in performance, not just 2% incremental improvement.
I agree with that. Anything that we tried, we got performance improvement over 30, over 50% in each of the improvements efforts we did before. And just to reinforce you, Mark, the healthcare industry is the most dangerous industry in the world. It's more dangerous than gold mining, than bungee jumping. It's more dangerous than everything that we know. So actually, it would be very clever to follow a lean strategy or other initiatives. We see a lot of great work done by IHI and the science of improvement they're using that are not quite different from what we're doing. It's different, but it's pretty similar, and they're getting amazing results as well. So I think that lean is not the right word for that, but it's the right idea behind it. The idea behind it is the same.
Mm-hmm. And there's a way of thinking it. When the way we think it, if you don't get better, you will get worse. Lean is an effort to try to make things better every day. So if you don't do it, probably your current condition will be worse and worse and worse. And again, to keep a performance stable is difficult. To have stability is very difficult. To have predictability is very hard. So what is the risk of not doing lean is getting back to worse, back to more mistakes, back to more errors. And lean is, I think, if you think lean in these terms, is the everyday effort to make things better. Maybe there's no other way for our healthcare systems around the globe, maybe.
Okay, we have another question. What is the best method to get the buy-in of top management and middle management to implement or develop lean in healthcare?
Want to go first?
Well, I can go first. I think that it's different strategies. Because middle management is the guy that is in pain usually in healthcare. He's the guy that got more workload, that he's the guy that is answering to the CEO and getting pressure to perform. So usually this is the guy that starts initiative. So usually the lean starts in middle management most of the time. And these are the first buy-ins. I mean, the first guys that usually understand what's going on because they can see processes and they can see what's happening. So if you're trying to start a lean initiative, usually it will start around it. But when you got into the CEO, well, Flavio got a statement on that. So you don't have to wait for the CEO. That's true. But you must be very careful about dealing with the CEO and showing him results, because CEO is looking for results. They're not, most of the time they don't have time to look for processes and to go deeper in what you're doing in your improvement initiative. You want to look for results, and what's best is customer oriented results. So start doing it with a small experiment and try to get the best you can from that, and then ask your CEO to visit you and to come, or your leader or whatever. I mean, this is not as fast as it should be, but usually works.
Yeah, I was going to answer, if I was allowed a one-word answer, how to get buy-in, I would say results. And that can apply at different levels. Lean can't be some sort of theoretical exercise. It runs the risk of, if you're not getting results, it runs the risk of being thrown out of the organization. I visited an organization in the United States. They had a group of people internally that were doing a lot of training about lean. They were using some lean tools like 5S. 5 years in, so you have the salaries of probably 6 people multiplied out by 5 years, plus the time, the value of the time of the people they've been training and doing things with. And I asked the leader of this internal lean initiative, so, at this point, 5 years in, what would you say your results are? And he said, oh, we're not worried about results. We're building capabilities. And I thought, you probably need to be building your resume, because there's a risk that you're not going to be given a 6th year to continue training and developing capabilities if it's not leading to anything. And look, I'm a big believer in the idea of the right process brings the right results. It's kind of a lean expression. You got to get results. So, I think it could be organizational results. A lot of times people ask a version of this question: how do I get physicians to care about lean? Solve a problem that matters to each physician. If it's a surgeon who's irritated and upset that cases are always starting late because instruments aren't ready, solve that problem. You can have an improvement initiative that is of service to the surgeon as an internal customer, and then you might turn that surgeon into the biggest internal fan for lean. Even if they haven't really yet participated yet, you're setting up lean as a positive. So results can be metrics, results can be make my day less frustrating. I think there are some leaders who connect to the philosophy. And they'll say, I believe I should get everybody involved in improvement, but I don't know how to do that. I believe that would be good for the organization, but I don't know how to do that. So sometimes you get that invitation, but still, results matter.
Well, I don't have much to add on that. I mean, your thoughts are exactly the way I think about it. But we must think about the impact. I mean, we must do things that have impact on people, on patients, and families. And what Mark said is just perfect. I mean, if you look at the physician, if you look at the doctors, nurses, if you look at the clinical guys, the people as customers, and we try to make their work life better, easier, lean is there. I mean, so make people's work easier. they will realize the power of that. And healthcare people, they're very attached to the needs of the patient. So if you impact the patient and you have him or her working in a better way, in an easier way, in a smoother way, no one can beat this. This is a very powerful force inside the organization. So this is what we look for when we start a lean organization or a lean transformation. Those kind of sparks, those kind of seeds that we like to plant. So you make people's life easier. That's the easy way to get lean stuck.
To add to that, we have a question from another individual, and he says, my question is how to find the problems, whether one should start with VSM or 5S or any other method. And I think, you know, Flavio, you're ideal to elaborate on that, given what you've just talked about.
Yes, I really think that you must go and see. The best way of understanding what's happening and go to the real place where the work takes place, where the people are, where the physicians are, where the nurses are, and observe their work. Understand what they're doing, understand the work, and understand the challenges that the people in charge are facing. So if you do that, you will realize that there's a lot of problems that probably most part of the time people are not aware of that. So the way to see is go to the Gemba. It's go to see how people work. How do people deal with the uncertainties? How do people deal with their daily work? How do people deal with the customer complaints? So it's easy to find problems if you're in the right spot, if you're in the right position. And sometimes people don't like to go to Gemba. Sometimes people like to manage by their office, just looking at some numbers and performance indicators. And when you can't see problems, it's because you're a little bit far from the real place. If you go there, problems will surface. Of course, you have to open the communication channels. You have to have access to people and what they think. But if you go to the Gemba, probably you'll be it won't be hard to find them.
Just one small add on that. I mean, it's very easy to find the problem when you're at the Gemba. And if you go there in 5 minutes, people will tell you what the problem they're facing. It's actually, I go to the hospital every morning and I ask, what's the problem today? And it's everybody knows that. But they need room to tell, they need space. I think that the idea of the Gemba is there's no place more powerful than it. So I don't have much to add about it, just Gemba.
Well, so one of the challenges of trying to go and help people identify waste in their own work is sometimes people get very accustomed to waste as being normal. So there's one level where you can ask people what frustrates you, and people will be able to bring up things that are apparent to them. There's risk, and this is where we have to coach them. You might ask, what's a problem today? And they might say, oh, we need more staff. Okay, wait a minute, that's a solution. That's a potential solution. Tell me about the problem. We don't have enough time to get our work done. Okay, let's look at that more. Why is the work taking so long? Right? So you sometimes have to coach people through framing, instead of framing solutions, help them really understand and articulate a problem or the waste. And then sometimes you've got to help people see waste that they've become blind to, if you will. So there are different methods like peer shadowing. Have one nurse literally shadow another nurse, and they watch the work being done. It's work they normally do, but watching someone else do the work is a luxury they don't normally have. So then they might look and say, wait a minute. Why, to gather the supplies to do it, you went from here to there, to there, to there, to there. Watching that sometimes is different than when you're actually doing it, especially when that's the way it's always been. So having, peer-to-peer shadowing can be eye-opening. Videotape analysis when patient confidentiality and privacy is not an issue. Sometimes when you videotape work and let somebody watch themselves work, they will identify waste that they wouldn't have thought to bring up just when you ask them. So I think, there are a couple things really at the front line, the waste in the work. Now, the person who asked the question raises a good point. If we start looking more broadly and kind of step up a little bit, value stream mapping and having a team go through that value stream mapping exercise can help identify waste at the boundaries between departments. That can be very powerful. And then I think if we step up even higher, as much as we talk about going to the Gemba, the reality is data can often point us in the right direction. So we can talk broadly about, well, we need to improve patient safety. All right, what's the biggest category of patient harm? Is it falls? Is it pressure ulcers? Is it medication errors? Is it central line associated bloodstream infections? We can use data to help prioritize what we go look at, because often at a starting point, there's so much opportunity, it can become overwhelming. So we can try to be strategic, especially when we're looking at really high-level systemic problems that executives can be involved in solving. The cultural issues, the systemic issues. And so just final thing I'll say, again, like going out into the workplace and relying on frontline staff, absolutely agree with that. But we also can't expect frontline staff to fix everything. That's unfair. There are certain systemic problems that only executives can take the lead on.
Okay, we have another question here. Sweta has made the comment that most of the hospitals and clinics are moving towards digitization of their current processes. However, I often see that such processes are still unstable and inefficient. So my question is whether the organization should go for lean transformation first to optimize their process before they go for digitalization, or does it matter?
I mean, I already stated earlier the idea of eliminate the waste first before you digitize anything. I think, and it depends on to what degree digitization. So one thing that frustrates me as a patient is coming into the doctor, being asked to fill out a form, and you've got the place to write your address, and you have the place to write your city. I used to live on a street called Meandering Woods Drive. None of the forms were ever designed with enough room to write an address that long. And so that's frustrating. And at some point you think they would see, like, I'm trying to squeeze it in, and somebody said, we should redesign the form to give a little bit space because some people have streets with long names. But then if they take that same bad form and make a digital PDF out of it and say, here, fill out this PDF online, I also can't get all of that to fit, right? So digitizing it may have some benefit, but we might also be digitizing the same frustration, and maybe there's less of a workaround. When I have a pen, I can make the letters smaller and squeeze it in, where a digital PDF, the text is the size of the text. And, so that, I mean, that's just one example, but it might not be a matter of making it I don't think we'll make anything perfectly lean and then digitize. If anything, it's cycles. Make it better, then digitize it, and then make sure as we have other ideas for improvement, we continue improving the digital nature of the work.
Yes, that's a very valid point, because quite frequently I've observed that organizations will make the decision that they want to go lean, and often when we go in, they'll, but we're already doing lean because we're working on this MRP system, or we're working on this special software. And when you start to look at the processes, it's like, now they've developed the capability to generate waste faster.
or sometimes it's different waste, right? So when we talk about digitizing prescription writing within a hospital, the old process was the risk of messy handwriting. Well, now everything's put into the computer. You've eliminated the risk of messy handwriting, but now you've introduced the risk of you accidentally hit the scroll wheel on your mouse and it changes the medication that the doctor had previously clicked on. So, you know, digitization doesn't always mean it's going to be more error-proofed than an analog process. We might be trading off one type of risk for another. So I think, you know, again, lean is not a cure-all. I wouldn't expect digitization or technology to be a cure-all either.
And there's one thing. Oh, sorry, Fred.
Oh, no, it's okay. Yeah. I think that we're facing the same challenge about safety, whereas digitalization is going everywhere, but the system is not becoming safer. I see. Well, there's a lot of digital processes in healthcare that maybe it's making easier to bill, but not safer to patients. I see it happening around here. We're struggling a lot with the pandemic and digital systems because we have to move faster to telemedicine and digital stuff and digital prescription and prescribing by phone. And we're facing big challenges around it. But the point is that at IOV, we start our processes, most of them in paperwork. And when we consider it valuable, we move them to our system. We create we find ways to build this process into the system, but only when it's valuable, because we must understand that the digital, making everything digital is not a real solution, because people are still asking for you to look at them, for you to talk at them, and the problems are still real problems, not digital problems. The problem in healthcare, as Mark said, from doctor scrolling down, the worst problem is the copy-paste in healthcare. Copy-paste is even worse than that. We see a lot of mistakes made by, I will just copy my yesterday prescription for today's prescription. And you get more antibiotics, more drugs than patients need, because you just miss the reviewing process. So it's not in the system, it's in your head. And sometimes it's easier to keep your attention with colors like those I have behind me, even though it's not the right solution for those who cannot see colors, but sometimes it's easier than just keeping up. We have another problem in healthcare is the overload of pop-ups in digital systems. Well, I work with them every day. I got bored. I mean, for each patient I click in, I got hundreds of pop-ups. It's not easy to look at them and to work with that. So that's a bad solution for a big problem. Saying, oh, this patient is allergic to a drug B, then another allergic to drug C, then another allergic to drug W and whatever. So these are bad solutions that we're not solving real problems. We're just doing ask for those pop-ups. And we're eliminating supposedly safe procedures that we are not using them. But they are there, and you say, oh, I got those safety procedure in my system because it pop-ups to the doctor, but the doctor rarely reads that in the real world.
And we as lean thinkers, of people who are thinking in lean terms a long time ago, since a long time, when I see digitization, I see a big batch of a one-time investment, like we're going to do this and we're going to solve all the problems. So it's a one-time event, and most part of the time we create the systems that are not flexible. So if we would like to make things digital, we should be able to do it in a flexible way. We should be able of changing the way we deal with the process by changing the technology. So what I see now is a very unflexible way of automation, of putting things in automated way. So, but of course, we are not looking at from the point of view of the doctors that are using, the clinical people that are using the system. So we are not user-friendly yet. We're far from that. And it's a very, a massive amount of money spent one time, one way, one event, like a big batch. We don't like big batches by definition. So if you can work with digitization or the digital world in small batches with small investments, incremental, adding capacity incrementally, that would be the easiest way of doing things. But most part of the providers don't like to use this way. They prefer to sell the big packages. It's much more money for them. So I still looking for flexible digital solutions for hospitals, not seeing it yet.
Well, and I would add one thing. I mean, yeah, I mean, I agree. Technology should be flexible. Technology is flexible. Sometimes the vendors of said technology are not flexible. I can't tell you how many times I hear from hospitals of, something that really creates a huge safety risk, and the vendor is like, yeah, we'll get to it at some point. And at some point, you've made that decision with the vendor, you're locked in. It would be incredibly expensive to switch. It's more of a vendor problem than a technology problem.
Completely agree, Mark. Is what we see here in Brazil as well.
Okay, another question. Are there any lean healthcare system softwares available? We know the answer is yes, but would anyone like to comment on anything that they are particularly familiar with?
Since I'm wearing the shirt with the software company logo,
Yes.
The pocket. So, I mean, it depends on what do you mean by lean healthcare system software? I mean, there are different software packages that can help accomplish certain things. Kinexus is a system that was it was software originally created by an ER doctor, and he's still the CEO of the company. And it was, the software was created to help manage the issue of how do we track and share and tabulate all of our improvement ideas in something that works better than a spreadsheet in a shared drive. So software can do things very well. It can help with communication. It can help provide visibility and transparency into what's happening. It can help with collaboration. It can help with tabulation of results. But what software does not do is the actual problem solving. That requires people. So Kinexus, is sort of created as an equivalent. Instead of being an electronic health record, it's more of an electronic improvement record. And as the company has evolved over the last 9 years, there are now customers in multiple industries. But I think it's interesting that the origin was there in healthcare, because the doctor was facing those problems working as a doctor. The leaders he worked with were facing those problems, and any technology should be created or used because it's solving. It comes back to that question of what problem are you trying to solve, and not looking at, well, what tool do I want to implement, whether that tool is 5S or whether that tool is software. So Kinexus is just one example of software companies that are trying to solve that improvement information problem in different ways. Bulletin boards are also a form of technology, by the way. There are pros and cons to these different technologies, to be sure.
Okay. As you rightly said, employees come and leave. So how can we build lean culture in our organization so that it's not dependent on employees? Also, on the contrary, lean is driven by employees only.
I don't want to be the first one to answer this.
Okay. Well, all right. I'm not shy. I'll jump in.
Okay.
I'm still thinking about it because.
So, I mean, like, to me, culture is this sort of collective norm around this is how we do things around here. So culture might say, for example, no, whoa, we don't speak up when we see a risk because we're going to get in trouble. Or the culture could be the opposite, where they say, well, the culture is, of course you speak up because there's no personal risk to speaking up. You get supported in improvement and problem prevention. And of course we would speak up because that's the right thing to do for the patients and for the organization, et cetera, et cetera. So like to me, the bigger risk, so like when you have culture, if one frontline employee leaves and you hire a replacement, that new employee can't change the culture. They're generally going to fall in line with the culture. The biggest risk is when the employee who leaves is the CEO. And I've seen this happen at too many health systems, some of which have had books written about them, some of which are mentioned in a book called Lean Hospitals, where a new CEO comes in and says, basically, I have no use for lean. And you'd like to think that, well, culture, it's difficult to change culture in a positive direction. That is true. It is very easy to destroy a culture almost overnight with different leaders who come in and start yelling and screaming and blaming people for not getting the results that the CEO thinks they're entitled to. That's the biggest risk, is not culture dependent. It's not employee dependent, it's executive dependent. Sorry, I get a little fired up about that.
Okay, here's another one. What is the difference in lean between healthcare and other industries? And I know that most of us have worked in many other industries as well as healthcare. So please, Fabio, elaborate.
Maybe not Dr. Fred, it's okay.
Right.
The basics, what we are trying to achieve is exactly the same thing. I mean, what we are looking for is the same thing inside every organization. We'd like to create a capability of getting better every day and improve the way we deliver things to customers. So this is basically Lean as an ideal, as an idea, is something that is similar. But of course, when you dive into the specifics of each business, you have to respect the language, you have to respect the power relations, you have to respect the organizational structures. So, of course, it changes. It depends on the sector, it depends on the industry, it depends on everything. But what is different in healthcare is that basically the key pieces of the systems are doctors and nurses. In my way, it's my personal perspective. And those people, they are trained using the scientific way of thinking. They know what science is. They're educated based on science. So I think it's easier somehow in healthcare because you have the scientific background. You just have to make people see that the scientific approach that they take when they look at the patient is the same thing they need to look at a problem, at organizational problem, at a problem at the different levels of the organization. So the scientific way of thinking is something that in my mind makes it's easier in healthcare somehow. But of course you're dealing with real people, real lives and families. And of course it brings us some different perspectives on how to deal with problems and things like that. But the basics are the same. And my point of view is that in healthcare, we cannot realize it, but we have a kind of a prepared ground for scientific problem solving. We just need to foster it. We just need to put some water. We just need to put, some things to make it easier so people can discover a different way of dealing with problems, a different way of dealing with management, a different way of dealing with the patient expectations. So I think this is the difference. It's more important, in my opinion, lean in healthcare maybe is more important than in any other sector for obvious reasons. We're not making cars. We're doing something much more important than that. We're saving lives. And of course, if some organizations are concerned with a minimum defect in a painting of a car, we should be the same, concerned with every details in how we're dealing with patients. So again, this is what in my mind makes healthcare a little bit different. But again, it's more powerful, it's more needed than any other sector.
I'd agree that
Okay.
the sense of purpose and mission in healthcare is extremely powerful. People use words like, healthcare is a calling. So the motivations in healthcare are really high. One challenge in healthcare is that because the motivations are so high, people will use workarounds. So you might have a very bad process, and because people care so much, they will stay late. They will do all sorts of things, if you will. Sorry, I'm using slang. They will jump through all sorts of hoops, and then the underlying waste never gets eliminated. So I've heard some executives in healthcare frame lean partly as, let's stop taking advantage of how much our employees care, because sometimes that caring and the workarounds and the extra effort leads to burnout. So that's the catch-22 between short-term and long-term. Short-term, people will make a bad process work okay. Long-term, they might get burned out and quit and leave. I think one challenge in healthcare is, I think through a lot of medical education, people are taught about the work, they're not taught about the process. And so trying to help people in healthcare start seeing their work as a process, and which is different than seeing our work as just a bunch of things we do every day, right? Helping people separate work into value and waste is sometimes difficult in healthcare. People will say, well, wait a minute, there was no waste. I was doing something all day long. The question is the activity value or is it waste? And so I think compared to other industries, there's sometimes, as much as I can generalize, there's less process focus, and we need to sort of help bring people's level of process awareness and system awareness up a little bit higher. I think one other challenge is there's a lot of things I think that are good and bad. In healthcare, people move up into leadership from doing frontline work. That's great. Like when I got hired as an engineer into General Motors in 1995, I didn't want to do this. I could have been hired as a supervisor. Like what right would I have to supervise people who've been doing this work for decades? I don't know anything about anything, but because I have a college degree as an engineer, you think I could supervise. But so in healthcare, I don't think that ever happens. Maybe someone gets hired as a clinical office manager without having a clinical background. It happens less often. The people running pharmacy are almost always pharmacists. The chief of surgery, I guarantee you, is a surgeon. That can be good, but it can also maybe perpetuate and reinforce old habits. So I think there's this balance where sometimes outside thinking can be really helpful, and people who have outside perspectives can still respect the people who have been doing the work for decades, right? So when I come into an organization, I try to be very careful. When I'm identifying waste, I'm not saying anyone is stupid. Like it's just a reality that there's waste in the process, and it's not your fault for not seeing it. But together, we're going to start seeing that waste, and we're going to build upon your ideas, and we're going to work to make things better. Anyway, I said a bunch of things that were unrelated to the question, but sorry. I hope it was helpful, though.
Okay, we're a little bit after the hour, and I don't see any new questions. So with that said, I would like to thank everyone for their time and the work that they put into making today's events possible. It's greatly appreciated. And for our participants, it would be greatly appreciated if you could put any comments or suggestions for improvement in the chat as you depart. And hopefully we'll see you all day after tomorrow for our last and final day of the Lean Gulf Summit. And for those in Dubai, good evening. For others, good afternoon. And for still others, it's still good morning.
Thank you.